Good morning. My name is Jean Nagelkerk, and I'm the Vice Provost for Health at Grand Valley State University. On behalf of the Health Forum of West Michigan partners, the Midwest Interprofessional Practice Education Research Center, the Michigan Center for Clinical Improvement, Michigan State University College of Human Medicine, Blue Cross Blue Shield of Michigan, and Grand Valley, welcome to today's event titled A Discussion of Health Disparities and COVID-19. Grand Valley is pleased to host the Health Forum of West Michigan on the first Friday of each month during the academic year. The purpose of the Health Forum is to offer a venue for exploring health topics pertinent to the well-being of our community. Through these forums, experts share information on thorny problems that affect each of us during our daily lives. Before we begin, I would like to thank Blue Cross and Blue Shield of Michigan. They are sponsoring today's event and the whole Health Forum series this year. And I'd like to recognize Diane Dykstra, who is our event coordinator, who plans all the details and coordinates this so that we can have a seamless event. Please mark your calendars for our next event, which will be the West Michigan Healthcare Economic Forecast, scheduled on Friday, January 8th, and it will be held virtually. The science and public health measures for COVID-19 continue to evolve. COVID fatigue, lack of personal protective equipment for some health professionals, increased hospitalizations, and the promise of a vaccine shape an uncertain time in our pandemic preparedness and response. There's a lot we still do not know about COVID, and new information and research is being released almost daily. What we do know, however, is that there are health disparities that are being exacerbated by COVID-19. Today, our panelists will provide you with an overview of the current state of the pandemic in Michigan, delve into the disparities worsened by COVID-19, and shares ways to improve these disparities through targeted initiatives and by reducing barriers and improving outcomes. Now, I would like to introduce our moderator for today, my colleague, Dr. Jessie Bernal, Vice President for Inclusion and Equity and the Executive Associate Vice President of Presidential Initiatives at Grand Valley. Dr. Bernal joined Grand Valley in 2015 and oversees the university's coordinated effort to advance diversity in campus and the campus climate. In 2019, Dr. Bernal's responsibilities were expanded to support strategy, engagement, and innovation for the Office of the President. Dr. Bernal also is an adjunct faculty member in the Adult and Higher Education Graduate Program, and he serves on several local, state, and national organizational boards, committees. He received his PhD from UC Santa Barbara and continues his research on education policy and law, organizational climate, and inclusive hiring. Dr. Bernal?
Thank you, Dr. Nagelkerk. And really, before I say anything further, I really want to pause to emphasize that appreciation. Dr. Nagelkerk, my friend Jean, you and your team have been tremendous in what has really been an uphill battle with COVID-19 at Grand Valley State University. You've been working tirelessly to keep our campus and communities as safe and healthy as possible for months. Your expertise, your collaborative spirit, and direct honesty is what we have needed, and it's inspiring. You've taught us all of us higher education professionals who I guarantee you never thought we would be operating what have really become our own massive public health facilities as we are today. It's a daily reminder to all of us who are not in the field of how appreciative we should be beyond this pandemic, the great work of our healthcare professionals. Each day, every day, you do things to save lives. So thank you, and thank you to your health colleagues for the heroic work you've led. And today we are joined by, I'll say it again, other heroes in the health profession. We're honored to welcome to today's forum. We're continuing, as Jean mentioned, our theme of delving into issues surrounding COVID-19 with a special and most significant focus on health disparities. As Grand Valley's Vice President for Inclusion and Equity and a lifelong social justice advocate and activist, there's really no more important conversation that we could have today. It's so important because of its interconnectedness to all facets of life and society. As an educator, I reflect on higher education's purpose. U.S. higher education's purpose is to enable individuals to pursue meaningful and progressive paths in life and work. Colleges and universities have most certainly been in its most uncomfortable place, uncertainty. And we will work to fulfill this mission in an era of COVID, cultural reckoning of racial injustice, and a yearning for transformation across our country and world. As my own President Philomena Mantella has said, the highly politicized discussion of remaining open during COVID has masked the question of why we remained open, why fight to provide access to learners in every modality possible. For us, the answer was in the most health-informed possible way. The physical, emotional, economic, and intellectual well-being of a generation is at stake. What some of our speakers today will talk to, the multiple determinants of health. Grand Valley State University is home to over 40% first-generation college students. We believe they deserve a well-constructed, well-supported path that anticipates and build the right scaffolding and support for what they need and what we can do to ready them for success. These students and all learners deserve inclusive and relatable modes of delivery. We know first-generation students of color, low-income students, often due to institutional barriers that are not their fault, have historically had fewer technology-enabled experiences available to them. We know that these modalities have yet to effectively replicate personal interactions and experiences for younger students. The availability of fully online delivery options as the only option puts these learners at risk without readiness. However, our ability to engage learners in multiple modalities has depended on our partnerships and the great leadership and guidance of our county health agencies. Thank you, Kent and Ottawa counties, and our regional medical partners. Thank you to all of our hospital facilities who have been great partners. So how have any of us been successful in higher education? Really only time will tell. But what we do know is that people of color, low-income communities, queer and trans people, undocumented communities and refugees, these and other communities our systems have historically excluded, have odds stacked against us. This morning, we will hear about data, disproportionate impacts, the history of what got us here long before COVID, and our partners are centering our underrepresented voices in their discussions, and we'll hear much more. And I hope we'll also discuss solutions on how we create a new equity, since we know systemic inequities did not begin with this pandemic, but maybe we can make some movement as we learn through it. Just last night, many of you probably know, Governor Gretchen Whitmer and the Michigan COVID-19 Task Force on Racial Disparities, chaired by the Lieutenant Governor, released an interim report detailing the significant progress Michigan has made in protecting communities of color from the spread of COVID-19. We'll hear a bit about that work today, and I encourage you all to review its initial findings, which really call for systemic change throughout our state. So thank you so much for joining us this morning. As for format, we will hear from 3 panelists, all medical and health professionals. Each will speak consecutively for about 15 minutes. During their talks, you are welcome to input questions into the Q&A box. Those questions will be tracked for each individual speaker and overall speakers if there are general questions. You may also include general questions in that Q&A box, and we'll ask those of all the panelists. We will not answer questions until all panelists have had a chance for their opening presentations. We have a large group here today, so I know we won't get to every question, but we'll document each of them. And I know I'm putting some of my colleagues on the spot, but I hope we can somehow share responses and thoughts to some of your meaningful questions if we don't get to them today. So with that, let me move right on to introducing our first speaker and panelist. Robert Orellana is a senior epidemiologist with CDC Foundation and is part of the COVID-19 response team assigned to the Michigan Department of Health and Human Services. In his role, he provides technical assistance to MDHHS on epidemiology and laboratory science in responding to COVID-19, including improving data quality, expanding surveillance methods, and addressing disparities, particularly among underrepresented communities. Dr. Orellana received both his master and doctoral degrees from Ohio State University College of Public Health, where he focused on infectious disease and antimicrobial resistance. Let's welcome Dr. Orellana.
Thank you, Dr. Bernal, and good morning, and thank you all for having me. It's great to be with you today to share an overview of the pandemic in Michigan, as well as to highlight some of the health disparities that exist with COVID-19 and really what public health is doing to address these disparities. So from an epidemiologist lens, I look at COVID-19 in several ways, a few of which I will share with you today. First, we'll explore what is the epidemiology of the virus SARS-CoV-2 in Michigan. How do severe outcomes like hospitalizations and deaths differ by populations and regions? And what are we doing in Michigan to ensure that there is an equitable approach to testing and care? And finally, how are non-COVID outcomes impacted by the COVID-19 pandemic? So before we dive deep into the data, I'd like to provide a 30,000-foot view of the pandemic in Michigan, and in particular, how we compare to the rest of the nation. Many of these measures you can obtain publicly from reliable sources like the COVID Tracking Project, Becker's Hospital Review, CDC's COVID Data Tracker, and Michigan's own public COVID-19 website. When we look at the raw numbers, we see that Michigan stacks pretty high with the 6th highest number of cases and the 3rd highest number of deaths. But we have to remember that Michigan is one of the larger states. So we also look at the proportion of cases to the population size. And we do rank a little bit better, particularly with our case rate, but we are still heavily impacted by deaths. So hospitalizations, one indicator of severe disease, shows that Michigan is ranked 7th for both beds occupied and for patients in intensive care. There is a silver lining, although I say this as a cautious optimist, but over the last week or so, we've started to see some of the metrics improve, like the case rate, percent positivity, and COVID-like illness. However, it's also important to note that we should not let up our efforts now, because we still have a long way to go. And this is apparent when we still see that nearly 20% of inpatient beds are supporting COVID-19 patients. And there were nearly 600 deaths just a little bit over a week ago. But we continue to keep up our testing throughout the state with over 60,000 tests per day, which is the first step to prevent spread. So first, let's explore the epidemiology of SARS-CoV-2 in Michigan. Here we have 2 graphs to show disease spread over time. On your left, we have the daily number of newly confirmed and probable cases by the date of onset since the start of the pandemic. We can see that the early spring peak right here in the months of March, April, and May, but more importantly, we can see just how quickly that spring peak was dwarfed by recent fall months. This is a trend that is seen throughout the nation, in particular in the Midwest, and it shows just how quickly SARS-CoV-2 is spreading among Michiganders. On the right, we have the cumulative number of cases by symptom onset date, and we can see that at least 380,000 Michiganders have been impacted directly by SARS-CoV-2, or I should say infected directly by SARS-CoV-2. So now we are looking at disease spread by place. Here we have an early indicator of disease spread, percent positivity, or the percent of positive tests divided by the total number of tests conducted during the week of November 21st through November 27th. From this image, we can see that SARS-CoV-2 is spread throughout Michigan, which is a telltale sign of community and widespread transmission. But we can also identify areas where there is more disease currently, as indicated by the darker shades of purple. Finally, we see who is impacted by the disease. On the top row, we have 2 figures breaking disease down by race. The figure on the top left is the cases per million population. Early in the pandemic, we see that Blacks and African Americans were disproportionately affected, shown by the dark blue line. In more recent months, there has been greater spread among whites, yet the spread among all racial groups is still high and concerning. The figure on the top right is the percent of cases in the past 2 weeks by race, shown here in the gray bar. And then the proportion of the population shown here in the black bar. So in the 2 most recent weeks of data, Blacks and African Americans make up 12.4% of all COVID cases, which is slightly lower than the proportion of the population living in the state. On the bottom row, we see similar figures, but it's for ethnicity. Hispanics, as depicted by the dark line, consistently trend higher over time than for non-Hispanics when we're looking at cases. And in the last 2 weeks, we see that they made up 6.5% of cases when we only make up about 5.3% of the population. So next we'll explore how severe outcomes for COVID-19 differ by populations. So the figure on the left and in the upper left, we see the total number of inpatients with COVID in Michigan over time. We can see hospitalization levels are near spring levels. However, I'll note that early in the pandemic, most of the cases and hospitalizations were in the southeast part of the state near Detroit, whereas now this is dispersed throughout all of Michigan. The image on the bottom left is the number of patients in the ICU. So we are about half of what we saw in the spring, and that is a better sign, but we can still see on the table here on the right when we break down by preparedness regions that we are still of concern throughout really all 8 regions, but particularly I've highlighted here in red. And just to kind of put in perspective, I've provided a map with the 8 preparedness regions throughout Michigan. So I think perhaps a lot of the audience today is probably from Region 6, perhaps maybe also Region 5 and Region 7. And really just the number of adult ICU beds with COVID patients is really high, above 30%. So we are monitoring that closely. And since we're not seeing a downward trend yet, as this is a lagging indicator of cases, we are working with our partners throughout the state to ensure that we can protect all Michiganders. So these figures are the daily and cumulative reported deaths in Michigan. It is a similar trend to hospitalizations with an early peak in the spring and a fall peak that is not yet exceeding the spring. But we are watching this closely as deaths are also a lagging indicator, meaning that those who died of COVID-19 today actually became sick several weeks ago. Now we see how deaths differ by race and ethnicity. Again, early months showed the highest burden among Blacks and African Americans, where there is an increase among all racial groups in the more recent months. However, Hispanics are not experiencing a higher rate of death, but I can tell you that looking into the data a little bit deeper, that currently the majority of Hispanics who are infected tend to be younger, but we do know those who get sick in the younger age groups will also spread it to the older age groups as well in their communities. So another way to compare deaths is by standardizing the case fatality rate. And here we are adjusting actually for age and sex. So the standardized CFR accounts for differences among racial groups, which allows for better comparisons between the groups and reduces potential differences like confounding. So during the spring peak, we saw the highest CFR among all groups. And as time went on, we saw our response improved. And so the CFR dropped for many groups. This is in part due to just the improved medical response as well as increased testing. Yet the burden continues to be highest among Blacks and African Americans. It's nearly high for all groups when comparing the CFR to whites. So now that we've seen that disparities exist in Michigan, what are we doing to ensure that there is an equitable approach to testing and care? Well, early in the pandemic, leaders in Michigan recognized those inequalities, as Dr. Bernal mentioned at the introduction. And so the Coronavirus Task Force on Racial Disparities was established. It is chaired by the Lieutenant Governor Gilchrist, and consists of 5 work groups focused on addressing access to care through telemedicine, equitable testing, connecting Michiganders to primary care, centering equity, and environmental justice. The response in Michigan has been recognized nationally, including in Politico, who reported that Michigan has one of the best responses to ending racial disparities. Today, I'm just going to briefly focus on the equitable testing component. So to ensure that testing is made accessible to everyone, 22 initial sites were selected based on a social vulnerability index throughout the state, shown here on the figure on the left. And we can see just how much testing has been conducted at these sites based on the size of, the diameter of the circle. An important feature of these sites was that there was a special contract with the labs supporting this testing to provide additional detailed epidemiology to continue to improve our response with minority groups. So from 21 of these 22 sites, there have already been 32,948 individuals tested. And of all those tested, 8.4% tested positive for COVID-19. Testing sites are definitely doing a good job to reach out to Black and African Americans, with 37% of all those tested identifying with that racial group. Yet there is still an opportunity to improve outreach to Hispanics and Arab communities. So finally, how are preventative services and access to care impacted by COVID-19? And these are indirect impacts of the pandemic. So here we see just a few indicators for preventative screening: a blood lead level testing and childhood vaccinations. The bottom left is the number of children who are tested for lead in their blood. And I do want to note that it's not children with high levels of lead in their blood. So in April, we see that testing fell about 75%, but it has since rebounded, although it still remains below pre-pandemic levels. On the top right is the childhood vaccination coverage for Tdap, polio, MMR, hepatitis B, chickenpox, and pneumococcal disease. Early data show that these series of vaccines remained relatively stable throughout the pandemic, although there was a slight decrease in trends. But I'd also like to note, again, just the starting baseline, particularly for Blacks and African Americans, is much lower than for the other groups. The bottom right is influenza vaccine coverage among children for the 2020 and 2021 season. So we can see that right now we are approximately 20 to 30% of coverage, but again, it's lower for Black and African Americans and American Indian and Native Americans. And so just to put this in perspective with previous years, typically we have about 30% of the population covered. And so we're doing a little bit better than previous years. We're also addressing Blacks and American Indian groups. So here are a few indicators for access to emergency care. The bottom left figure shows the total emergency department visits for all complaints. And we can see that there was a large drop after the stay-at-home orders were in place. And we've since then improved, but we're still about 13% below normal levels in recent weeks. The upper right shows the number of probable opioid overdoses responses made by EMS. And we can see that opioid responses increased approximately 22% since 2019. Finally, in the lower right, we see the number and the rate of meth-related emergency responded by EMS. And again, we can see that methamphetamine-related emergencies increased an average of 16.2 calls per month compared to 3.9 in pre-pandemic period. So finally, I'll just briefly touch on all-cause mortality. We look at the all-cause graph here on the left, and this is publicly available on Michigan's Vital Records website. It shows the weekly total deaths in our state. And what's obvious is the spike in deaths and what proportion is related to COVID-19 here, shown in blue. Just for comparison, we can see the black line is the previous 3-year average. The graph on the right then takes those data for the current year and stratifies it by race. So here again, if we look at that black line, that's the state number. And then we can see that the gray line there is the all-cause mortality for Blacks and African Americans, much higher proportion than for the other races. So finally, just to put this kind of in perspective with other diseases, a pseudo control is just the Michigan heart disease deaths in the state. And again, on the left, we can see the past 3 years by the blue lines in comparison with the black line, which is provisional data for 2020. We did see a little bit of a spike, and part of that may have been actually due to folks not seeking care during the stay-at-home orders. And again, when we break this down by race, we can see the gray line there with Blacks and African Americans having the largest burden. So how do we continually, how do we successfully fight COVID-19? Well, we need to continually use data to drive our success. We need to stay the course with strong and effective mitigation measures, things like watch your distance, wear a mask, wash your hands, and provide appropriate PPE to healthcare workers. We need to provide rapid and accessible testing with quick turnaround time so that information is valuable. We need to continue with the box it in approach to quickly conduct case investigations, thoroughly reach close contacts, and make it easy to follow isolation and quarantine. Next, we need to provide support for living in the new COVID normal. And when available, provide a safe and effective vaccine, which is really just around the corner, but it's not going to be available to everyone immediately. And finally, it's important to remember that all these steps should be done with an equitable lens. Thank you.
Great, thank you, Dr. Orellana. Such meaningful information and data. I'm sure there will be lots of questions. I know I have some that I want to jump into, but let's move on to our next presentation. Dr. Nedd is an internal medicine physician, a community leader, entrepreneur, and researcher. He presently serves as the CEO of Answer Health, a West Michigan clinical integrated network of over 1,000 independent physician providers. He's also the president and owner of Infusion Associates. Dr. Nedd is renowned for his work around building strong communities and for his work addressing healthcare disparities. He was one of the founders of the Grand Rapids African American Health Institute, a West Michigan organization addressing healthcare disparities, utilizing a three-pronged approach of education, research, and advocacy. Dr. Nedd received his medical degree from Michigan State University College of Human Medicine, and he completed his residency in internal medicine at Blodgett. Please welcome Dr. Nedd.
Thank you, Jesse. Good morning, all. Thank you to Grand Valley State University for hosting and Blue Cross Blue Shield for sponsoring this very timely discussion on the impact of this horrible pandemic. GRAHI and the Grand Rapids African American Health Institute, which is GRAHI, and GVSU have had a very good partnership, at least since the inception about 18 years ago. As you know, we are housed at the university, at the college, and we collaborate and share resources around a lot of initiatives, and we enjoy a close and hoping for even, over the next several years, a closer relationship. Personally, I want to thank Jean Nagelkerk, and the rest of the GVSU staff for making this bold step. and taken bold action on some of the work that they have done with us around, the issue of healthcare disparity. So I have no disclosure, with the exception that, based on my race and age and probably some other medical conditions, I'm a high-risk guy. So this is, our vision, for Graha. That's something that you can easily, read. And our mission is to promote healthcare parity in the Grand Rapids African-American community through advocacy, education, and research to achieve positive health outcomes for its citizens. So I'm sure you have seen multiple, of these headlines in various news and media sources, and obviously you've heard from Dr. Orellana the conversation around some of the data that the state have. It's really commendable in Michigan that we are doing, quite well in terms of a response. So kudos to those who are doing that work. These headlines and these findings, while they are very alarming and probably tragic, it really illustrates, the kind of things that actually gave birth to the Grand Rapids African American Health Institute. This storyline for us, is a recurring theme of what the structures of healthcare disparities and populations of color, in particular African Americans, have been. Part of the work of Graha is actually to shine a spotlight on these disparities and to use a scholarship where necessary in gaining a better understanding, of the structure and anatomy of disparity. And actually part of our job is to, do the mechanical work of disassembling or deconstructing some of the structural elements of disparities. And to really work with community to find, ways to mainstream solutions that can keep pace with the fast moving changes that are occurring in healthcare. As you know, some of the paradigms of the past, would not be able to solve the new problems that are existing in healthcare disparities. So I'm going to use this iceberg model, which I think, many of you have seen in the past. Healthcare disparities it's a very complex kind of a problem, in that what you see on the surface, there is a lot more underneath. If you take the pandemic, for instance, the pandemic would represent what you see at the top of the surface here, but you can actually replace the events of the pandemic with many other diagnostic entities in African American populations. This can be replaced by, infant mortality rates. It can be, disease burden from hypertension, diabetes, stroke, heart disease, other infectious disease, kidney disease. There is a saying, from birth, to death, African Americans sometimes are representative of some of the more difficult outcomes when it comes to healthcare. But the power here is saying that what's underneath the surface, a part of some of the driving forces, things like social determinants of care, disenfranchisement, education, racism, safety net issues, issues around housing, employment, poverty, and sometimes just, cultural beliefs. In the last, over the last 100 years, we have seen a tremendous occurrence of astounding inventions, over the last century, and particularly if you look in the last several years, as it looks in terms in the area of molecular science and genetics. And if you go to the top end of that bar, you can also take Operation Warp Speed and probably just plant it right there too. And in terms of what we have done in the last few months, and really driving to the beginning of investigating, finding out a vaccine for this COVID-19. to the time that now we are on the verge of having an answer to this, this is quite a fast pace and just speaks to how things are changing rapidly in terms of healthcare. Alongside this, alongside these great inventions and these great treatment modalities and care designs that have existed, over the years, we have seen also, an age-adjusted and crude death rates in Americans have moved in the right direction, in terms of the pace of improvement. But, as you look at, when you compare African Americans to white population, even though the good thing here is that there has been, a decrease in mortality rates in African Americans, it has not kept the same pace of what white Americans have enjoyed, which explains some of the disparities that we talk about. I'm going to use this as, for those of you who are purists in terms of thought models, I'm going to use an illustration here that I think, hopefully can bring to bear the complexity as we look into what I call the anatomy of healthcare disparities. That first line kind of represents what I will call medical advances. This is the place where, things are coming out of the laboratory and out of, the great scientific communities, of science. And that would represent, what we talked about already. There is the pace of improvement in inventions are just significant. But when these inventions occur, when they come out from the laboratory, before it actually gets to really some kind of clinical implementation, and I would say usually that probably occurs at the more elite centers, probably the Mayos of the world or the Cleveland Clinics, the major medical centers. And then it takes a little time, before it becomes available to the common everyday primary care docs in the practice in our various communities where we reside, which I call, the availability to the general population. And that difference probably represents what I like to call the implementation gap. But for African Americans, oftentimes our access, to a lot of those modalities of care are kind of delayed, and that's kind of what I call the disparity gap. The idea here is that, and hopefully actually in this COVID experience is one of the things that we are seeing, is that, in the last, few months, we have done very well in creating a vaccine. The idea here is to make sure as we have implementation and hopefully we can close the disparity gap so that that red line can be much closer to the broad orange line of medical advances in terms of, say, the work of closing the disparity gap and the implementation gap, so it's much closer for everyone in more of an equitable sense. It's something that we want to work towards. I think this slide also, illustrates something for some of you who might be on the line, who are probably coming from the business world or other healthcare areas. I think there are opportunities here, not just for the COVID experience, but the opportunities here is that this difference between, the African Americans' participation in healthcare to when these medical advances occur is a cost metric that means it's more expensive care. I believe closing those lines, while the utilization might be up, I think the outcomes and the burdens to families and the burdens, to employees, et cetera, would be less if we were to address these things. So, this I sometimes, like to refer as, the common sense theory of change. And when I say common sense theory of change, you hear this all the time where people say, if people would only exercise more, then they will be healthier. If they would only eat better, it would be such and such. If they would only stop smoking, if they would only pick themselves up and do something, then they will. While there may be some truth to that theory, in essence, it is not a strategy for solving a complex problem, that healthcare disparities. So how can we make changes? How can we possibly make a difference? We already talked about, the determinants of healthcare are multifactorial and not really single. So I'm not going to go over this, but I want to make a bold and possible, entrance into what I believe are some of the things that we can do to not just address, the COVID issue now, but to really address the systemic issue of this healthcare disparities, and that is to take something from the value-based arena and say, how can we make healthcare disparities a quality initiative? As value-based principles, around the triple aim and payment models and payment incentives, so forth. What if we were to, make healthcare disparities truly a quality initiative? So what are quality initiatives? Quality initiatives are generally these high priorities that, that exist in healthcare that are adopted by, health plans and other payers. They usually, bring along with them some quality measures, which are tools that helps us measure or quantify healthcare processes, outcomes, patients' perceptions, and organizational structure, and or systems that are associated with the ability to provide high quality healthcare and are related to one or more quality goals of healthcare. Of course, these goals will have to, provide effective, safe and efficient, patient-centered care that's equitable and timely. Essentially what I'm talking about is that, at the end of the day, it is always said you follow the dollars to some degree. And if you really if you really believe that something like healthcare disparities is such a cornerstone, to the elements that we have just talked about, what if we were to make it a priority in terms of driving it as a quality initiative? Using the same principle of the triple aim that we know, with the IHI. So I'm just going to move quickly to what I would call the stakeholders in this. Who are the stakeholders in healthcare? The patient, of course, is always at the center, and hopefully it expressed this sense of equity in terms of saying that all patients can really enjoy that benefit. But who are the other stakeholders? The stakeholders are, government, government-run programs, hospital systems and their interaction with how they deliver healthcare, providers and provider networks, which is, more the provider side in terms of how they interact with patients, and obviously, the employer-based health plans. The idea here is that if specifically each of these stakeholders, one is to get government programs like Medicare, Medicaid, et cetera, to start reporting quality outcomes by race, ethnicity, and language. Also, create payment incentives for quality improvements by race, ethnicity, and language, and data collection, which can be followed by rewards for these quality improvements, and sometimes followed by penalties for those who are missing the mark. Of course, these rewards should, reflect case index advantages for providers who are seeing more diverse patients, to encourage more providers to be involved in the care of those patients. Employer-based healthcare plans, the same thing, encourage reporting of quality outcomes by race, ethnicity, and language metrics, creating payment models that rewards for quality around collecting this data, but also to do rewards for the quality improvement that's achieved, and follow by penalties wherever necessary, those that are missing the mark. And doing the same thing in terms of the rewards, for case index, especially for those individuals who are seeing those populations that comes from more diverse background. What can employers do as the others? Obviously employers have the bully pulpit. They pay for this. They have the burden of the cost, in healthcare. And hopefully they can drive these initiatives around your influence in terms of your interaction with the health plans. Of course, we'd also believe that companies who really seek to have a more diverse, social, responsible environment in creating a workforce that reflects our society, health outcomes in those areas would also be would be much more of a priority. Hospital system, pretty much the same thing, adding quality metrics on race for all quality initiatives and benchmarks and scorecards, and changing the model of payment, for those individuals. From a provider sense, is really rewarding providers for achieving these very metrics around, race, ethnicity, and language. What are the patient's responsibility as the other? It's education, responsible education that goes to, families, helping patients to, understand the tools that makes it easy for them to navigate around healthcare, and providing incentives that goes towards some of the metrics that can be met around their interrelationship with the healthcare plan or the hospital institutions or wherever they interact in healthcare. So this is kind of just an overview of saying structurally, what I believe are some of the opportunities that we can use in more of a model that I think matches or parallel the changes that are occurring in healthcare. Healthcare is moving at a rapid pace, and if we are going to use the same archaic or kind of an old mechanical way of how we really approach these structural changes, we will be continuously behind the 8 ball. The idea is to say, let's look at where healthcare is moving. Let's look at where the changes are. The train has already left the station as it comes to value-based care. And if we are going to really enjoy the benefits of decreasing these disparities that do exist in African-American population, we must mainstream and catch up to where it's going. Hopefully we can tease out some of this further in additional question at the end here. Thank you.
Thank you, Dr. Nedd, and thanks for your longtime service to our community and the great work of Grahi. I know Grand Valley is really proud to be a partner with Grahi as well. Our next presenter, Dr. Leslie Pelkey, is the Chief Medical Officer at Cherry Health and a principal investigator for Johnson & Johnson's phase 3 COVID-19 vaccine trial ensemble. She's committed to improving health outcomes for those facing inequities in access and quality care, and she provides a clinical perspective to advance Cherry Health's mission by leading the necessary cultural change and collaborative efforts to engage individuals and align resources in order to improve population health and overall patient and staff experience. In addition to her leadership role at Cherry Health, she continues practicing medicine as a board-certified internist at Heart of the City Health Center Adult Medicine, where she also enjoys working with students across disciplines, including pharmacy, social work, and medicine. Dr. Pelkey graduated from the University of Michigan Medical School and completed her internal medicine residency at the University of Virginia. Welcome, Dr. Pelkey, and thank you for being here.
Oh, thank you so much for having me. Good Friday morning to everyone. It's really nice to be here this morning talking about this topic that is near and dear to my heart. Health disparities have actually been present for hundreds of years, impacting chronic disease management as well as life expectancy. Cherry Health is Michigan's largest federally qualified health center, and as a safety net provider, it is our goal to reduce barriers to care and improve outcomes, regardless of individuals' ability to pay for services, so that all people have the opportunity to reach their full health potential. And today I'll be kind of reviewing some information about Cherry Health and some initiatives that we've put in place to achieve that. Next slide, please. So many factors contribute to disparities affecting multiple different populations of individuals, including LGBTQI, the racial and ethnic minorities that you've heard about today, as well as many others. But one important central driver brings some of those groups together. And so poverty, we find, is one main driver of the poor outcomes. This graph shows life expectancy for 40-year-olds and how that changes depending on income. That top orange line represents the top quartile of mean income And you can see that life expectancy drops from the upper 80s down to the upper 70s as income declines as well. And this disparity actually even widens further if you look at the top 10% or the top 1% compared to the bottom. Next slide, please. This is relevant because the vast majority of the more than 66,000 individuals that we served last year were at 200% of the federal poverty level or below, and nearly 3/4 were at the federal poverty line. Just so for reference, for a family of 4, that's $26,200 annually, and 200% poverty is twice that, so around $52,000. Next slide. In addition, the majority of patients that we serve are people of color who experience that institutional racism, which is another very important and independent social determinant of health. So it's important to us that our staff reflect our community. That alone we know can help improve health outcomes. And training staff for cultural competencies and implicit bias trainings. And just have staff that really care really makes a big difference. Next slide, please. As shown here, 21% of the patients that we serve have no medical insurance. That's that black piece of the pie. This has actually decreased over the past 8 years due to the state's Medicaid expansion. And we have staff actually on site dedicated to help with insurance enrollment for those individuals who still are not having access to medical insurance. Not shown here is that about 1/3 of our visits do require interpretation services, the majority of which is Spanish, but we really have languages from all over the world that we serve. Next slide. So what we do, I'm not going to go through all of these bubble by bubble, but we do have quite a few services. Since many patients are at risk for health disparities, historically we've addressed this by offering a broad array of services integrated within our clinics, utilizing a sliding fee schedule to make that comprehensive care both accessible and affordable, going for that, one-stop shopping experience, for convenience. However, we also know that some individuals aren't always ready to engage in every single offering. So we really focus on meeting people where they are, taking one step at a time, developing that very important key aspect of trust with the long-term goal of hitting some of those quality metrics that Dr. Nedd was talking about. Reaching those who are coming in regularly for their visits, as well as maybe some of those who haven't been in for a while, who've been lost to follow-up care. Next slide. So in addition to really focusing on those quality metrics, closing gaps in care, we do screen for social determinants of health and address them. This chart includes responses from patients from our primary care clinics so far this year, including prior to the pandemic. I actually suspect that these results may be an underestimate of need, as people generally prefer not to share this type of information. At the top, you see food. 19% of individuals did report food insecurity. And this makes it hard for them to take medications, for example, that you need to take with food. So it impacts chronic care for disease management, as well as, of course, exacerbates behavioral health issues such as anxiety and depression. So connecting our patients and individuals in our system to community resources to address their social needs is vital. And this is accomplished utilizing care managers, social workers, community health workers, AmeriCorps members, and even students within our clinics. Next slide, please. Now for COVID-19, this storm of a pandemic has really affected us all, but again, not equally. Some of us are facing this storm in the relative comfort of the ocean liner there, as you can see, while others have significantly less support and are just barely hanging on to some floating debris passing by. Next slide. So as COVID-19 hit Michigan at the end of March and the beginning of April, the number of kept in-person visits dropped precipitously at Cherry Health. Clearly, patients weren't getting the regular care that they needed. So like every medical system, we did swiftly implement many changes to keep both patients and staff safe, and that included telemedicine, both to manage chronic conditions and address behavioral health needs, as well as keeping people off public transportation and out of the emergency rooms. One extra challenge for some of our patients, though, is some did not have access to smartphone devices or internet availability. And so we have been distributing cell phone and limited service contracts to patients who are needing those. So I'd just like to point out here that telemedicine has been one very important silver lining, I think, in this dark gray COVID cloud. It has helped break down barriers and increase access to care. Plus, it's offered new information that we never had access to before. For me to be able to see inside someone's home and ask them to show me their refrigerator, their cupboards, or that very important medicine cabinet has really proven to be very valuable. Next slide. However, not all visits can be done well through telemedicine. We saw that there was a dip in childhood vaccinations, for example. We definitely continued to want to reach people who weren't able to come into the office. Those with hypertension and diabetes also need to have objective measurements taken to have a meaningful visit. So we implemented workflows to get blood pressure monitors out into patient homes where they could check their own blood pressures. And we offered things like drive-up A1C testing to evaluate blood sugar control. And then we continued, like I mentioned before, those important in-person visits for children who were due for immunizations, for pregnant women, for dental emergencies that needed to be taken care of. Next slide. Also on March 25th, a new COVID-19 call center and associated drive-through walk-up testing site was launched. It serves both Cherry Health patients as well as the community at large, including those experiencing homelessness in our neighborhoods. Next slide. And since that time, we participated in multiple community events to do weekend testing in those higher risk areas where we were seeing concentrated COVID-19 cases. And in addition, we traveled to farms throughout the region, serving more than 2,700 agricultural farm workers. Testing has now expanded, so we're also doing influenza A and B testing, strep testing for those who are needing that as well. And I wanted to put in a big plug for flu shots. We're delivering flu shots, and actually they're free from now through the end of this year for adult patients in our drive-through site. And at this time, I'd like to point out another little silver lining. During this time, there has been tremendous coordination with the hospitals, with the health department, with universities, local community organizations to better serve our community. It's been a time of really great collaboration, and that's been an exciting change or improvement. Next slide. Here you can see the Cherry Health data of COVID-19 positive test results by race and ethnicity. It is what the world has seen, what the state information reflects, then was shared this morning. There's no doubt that COVID-19 has exposed health disparities or poor outcomes in ethnic communities, many of whom face crowded living conditions or work at essential jobs that result in higher risk exposures or have underlying chronic health conditions, which put them at increased risk. It's no doubt that people of color have shouldered a disproportionate amount of COVID-19 disease. Next slide. So to help reduce the spread of COVID-19 and protect those at highest risk, of severe disease, we noted that one gap in those being screened and tested was just a lack of masks. We know that's an important part of the mitigation strategy, as masks have clearly been shown to be effective at reducing transmission of COVID-19. So with help from individual and corporate donations, we continue to give away masks for anyone who is in need. Next slide. The pharmacy has also played a key role in reducing disparities. Number one, by passing on discounted medications to patients. So medications that could be very expensive, like insulin or respiratory inhalers that are life-saving and very important, can be given to them for pennies on the dollar. And in addition, during this crisis, our pharmacy now offers free home delivery for our highest risk patients and curbside pickup as well. Next slide. I would be remiss if I didn't mention behavioral health. This pandemic and the associated sheltering in place, which was required to help mitigate spread, has certainly led to social isolation, school closures with untold effects on our children, and widespread job losses and financial issues for many families. Emerging evidence also suggests that COVID-19 may have direct neurologic consequences as well. There was a recent CDC report from August demonstrating that mental health issues that previously affected about 10% of the population now affect 40% of the population. And again, those with those daily wage jobs are far more likely to be affected than those with salaried positions, and they have poor access to care. Also, frontline workers, of course, have been experiencing increased workload, trauma, making them more susceptible to stress and burnout, anxiety, post-traumatic stress disorder. So we are actively screening for behavioral health disorders and referring to treatment when indicated. Our behavioral health teams have been extremely busy, and again, telemedicine has actually been a lifeline here. With over 90% of our behavioral health visits still being conducted through telemedicine. Next slide. There's also been a rise in use of substances. Our methadone clinics located here in Grand Rapids as well as Muskegon serve more than 1,300 individuals, many of whom had previously received daily dosing for their treatment. Immediately in March, it was clear that having long lines of very high-risk individuals in a crowded office space was an unacceptable risk to public health. And so our teams really closely monitored each individual patient and determined which might be able to go to 1 week takeouts, 2 week takeouts, 1 month takeouts, while closely following them up to make sure that the risks were controlled. In addition, we've continued to onboard new patients for treatment, and in fact, intakes have increased by 30%. We also have continued our primary care office-based treatment programs where we serve individuals with buprenorphine and long-acting naltrexone. Next slide, please. Another silver lining is the rapid advances that we've seen in science and healthcare, especially vaccine technology. We're pleased to be participating in the Johnson & Johnson vaccine trial with the Ensemble team and are currently enrolling individuals in our downtown office. This is funded by the NIH, BARDA, and as part of Operation Warp Speed. In addition, 3 other vaccine candidates have already begun to show very promising results and may be available soon through the emergency use authorization. And Cherry Health will play a partnership role with a partnership with the state, the local community organizations, public health, to help distribute and administer the vaccine safely, equitably, while closely following CDC and state guidelines. Next slide. I'd just like to end by letting you know at the end of an office visit, I typically ask my patients if there's anything else I can do for them, if there's anything else that they need. I can't tell you how often I hear the response, could use a few extra bucks, doc. And it breaks my heart because I can't write a prescription for that. And I know they need more than just a few extra bucks to solve their problem. The initiatives discussed today actually have significantly reduced barriers to care and improved health outcomes. Cherry Health is closing gaps on blood pressure control, immunizations, many other quality metrics, and has been recognized for that. Our staff work hard doing all they can together with community partners to address the downstream effects of poverty and institutional racism by reducing barriers to care. But we actually need the upstream solutions to solve this larger societal issue. COVID-19 has brought new light to this problem, and I think acknowledging and addressing healthcare disparities is potentially the best silver lining of all, because I really think we can do better. Thank you.
Thank you, Dr. Pelkey, and thank you for the great work you help lead at Cherry Health and serving our community in such important and patient equity-centered ways. And I want to thank all of our speakers as you turn your cameras back on and come to join us as we answer some questions from our attendees. Again, if you have questions for any of the panelists or for a specific panelist, please use the Q&A function at the bottom of your Zoom screen. You can do that anonymously if you so choose. I see some folks offering opinions that they'd like some reflections on, which is going to be a great conversation. Let me start with a general, well, not a general question, a specific question. So as I mentioned and Dr. Orellana mentioned, yesterday, the governor's office and lieutenant governor's task force issued its interim report. And the task force identified a number of areas that they would have concerted focus on, particularly as we head into the holiday season. And want to get your reaction to these. I mean, it's a report. I'm probably the only nerd that stayed up overnight reading it, but you know, I'm going to summarize sort of the 4 recommendations around that report. And some of you have already touched on these, but want to get your reaction to whether these are the right recommendations for immediate action moving forward, or if there are others as well. The first is closing the digital divide. Dr. Pelkey, you talked about this in telehealth and virtual learning to ensure equitable access. The second is to increase enrollment in mental and health insurance plans by making it easier for Michiganders to find out their options and get affordable health care. The third is building mobile testing infrastructure. Dr. Orellana, you talked about this as well, that can be extended for other health services, such as the vaccine administration. And the fourth is raising awareness of racial and ethnic disparities within the medical industry, medical professionals around healthcare. And Dr. Pelkey, you and Dr. Nedd spoke to these. Are these the right next steps? What more should be done? Or can you speak to more detail to any of those? Let's start with you, Dr. Orellana.
Absolutely. So I wasn't the primary author, but I certainly provided some input into the document. And I do want to recognize that we at the state level realize that these are not all inclusive and all encompassing to address all the racial disparities. But we do feel that these are some of the most important given what we've seen right now. So I think all of the points that you brought up are tremendously good. Of course, you know, I mentioned the 5 work groups that we have within the Racial Disparities Task Force, and they are trying to address not only the points that you mentioned, for example, accessing broadband and having telemedicine and primary care more accessible to different groups, but also to address more of the upstream factors. So I think that's an extremely important issue to raise, and we are continuing to work on it. We certainly are not seeing this as the end of the line. We will have many more recommendations and updates, you know, in the weeks and months to come.
I think you're on mute.
Yeah, Dr. Nedd, I think you heard me say your name, even though I didn't say it out loud.
You know, I think those 4 areas, I think, are a great start. I would say, you know, what makes a good healthcare system, I think, is the ability to deal with the issues that presents themselves in an emergent situation like what we're experiencing, but also it's the ability to have the distant and more, permanent changes that we can really do at the same time. And, one of the things that I do believe that, and I think I was trying to get to that at the end of my presentation, and that was this idea that, if you really believe that healthcare disparities really exist, and you believe that its impact is as we all describe, then let's do what we do for other quality initiatives. Let's tie incentives to them. And I think that's what I think, I think and saying, how do we, we have strokes, we have heart attacks, we have, obviously the pandemics and other things, but, what if we thought to begin this idea of rewarding, the systems, the places like Cherry Street, the providers, who are actually doing the work and showing the metric of improvement. And also, the idea that that will drive, I think, more providers, more hospitals, more everybody to say that, we're all in this together. And the last point I would say about this is that I believe that in as much as we identify healthcare disparities as the problem for what it is, I would say that it's the most significant opportunity from a financial standpoint. A business model of saying that if you were to engage incentives and rewards that goes to the people who are caring for those patients, not only would you do the morally right thing of lifting the outcomes for patients and their families, but it will cost us less because the way healthcare would be utilized and so forth. So that would be the only additional steps that I would think about saying, is that how do you look at some permanent changes into the future? Because we're going to have more pandemics, or we're going to have more epidemics, and we're going to have other things that affects populations of color or vulnerable populations. And so that would be some of the things that I would add to that.
Thank you, Dr. Nedd. Dr. Pelkey?
Yeah, I think one other thing that hasn't been mentioned so far is my experience is trust with those communities is very important to be able to deliver good, positive care. And I think, like I mentioned before, having the workforce that reflects the community is important, and to put in place, to bring individuals from those communities and get the education and the training so that they can be part of the medical system. And reimburse things like community health workers that we have that we're losing money on, but that are so important because they can go to individuals to talk about how important a colorectal cancer screening test might be. Whereas if they're hearing that from me, they might not want to do it. But if they hear it from someone they know who's in their neighborhood, who's had it and been through it, those are the types of things. I think connecting with that community really at a level that there's a good degree of trust is important to be able to close those gaps.
Right. Thank you, Dr. Pelkey. And a question for you, Dr. Pelkey. Speaking of trust in underrepresented communities and underserved communities, can you share more about the work that you and Cherry Health are doing with agricultural farm workers? What lessons have you learned that maybe the public health system should implement moving forward, not just in the pandemic, but beyond that?
Right. Well, that was a great project for us. It was really busy in a short period of time, going, like I said, from farm to farm throughout the region. That was under an executive order. So because agricultural workers are such an important part of our food chain supply, it was really important that we were able to make sure that those individuals were tested and isolated if need be, so that we could maintain those important food delivery systems upstream. So what we did is we worked with multiple different groups in the state and the migrant teams. I forget all of the different organizations that we partnered with, but it was an extremely coordinated effort, and we met on a weekly basis. So the health department was there, as well as people with housing and food services. And so we would go into a camp and we would test however many individuals were at their farm, and that could be anywhere from 10 to 12, up to a couple of 100. And we would have interpreters there available because many did not speak English as their first language. And then we would work with other teams to deliver the results and to make sure they were isolated and there was housing available at a YMCA camp so that they could enjoy their isolation in a safe way and receive the things that they needed there with check-ins from medical providers as needed.
Thank you. Dr. Orellana, a question from you from one of the attendees. What do you think explains, or if you have facts about this, explains the high case fatality ratio among Asian populations in Michigan?
Yeah, that's a really good question, and I do appreciate it. So there are a couple things that go into play when we do look at these data. First off, I don't have the screen up, but I can share that if that would help. But we saw that early in the pandemic, actually, Asian and Pacific Islanders were doing better than whites, and all groups improved, but whites improved the best. And so part of that comes into just the structures that are already in place and how they serve different communities. So I think we need to recognize that the current structures aren't advantageous to minority groups. The second that might play a little bit into this, even though the data are still, we have a lot of cases, we still have a very few number of cases of Asian American and Pacific Islander. I don't know what the number is off the top of my head right now, but if you go to michigan.gov/coronavirus, there's a dashboard and you can break it down by race, and Asians and Pacific Islanders make up a very small fraction of those who are impacted right now. And that could be for a few different reasons, but really when we're dealing with small numbers, when we're looking at the comparison of 2 deaths per 100 among whites versus 2.5 or 3 deaths among Asians, how much really is that difference perhaps due to, from a statistical mindset, random chance? And so I just kind of want to acknowledge that, as we start to collect more information, or more information comes into us as the pandemic progresses, we might see a balancing just because we saw it more advantageous towards Asians and Pacific Islanders early in the pandemic. And it's now shifted in the other direction. So it'll probably kind of wash out, but it's certainly something that we are watching. We're watching for all of the groups that I mentioned.
Thank you. Dr. Nedd, this is, we know there's a mistrust within the health industry because of, past experiments, the Tuskegee experiment, some of the current federal policies that are being extended or passed by, or implemented nationally that disproportionately create, distrust from communities of color in particular. One of our attendees is asking, or states, one of the major challenges they believe will be closing the implementation gap for COVID vaccine for high-risk populations, communities of color. With this distrust, can you speak to what is being done or what should be done to promote trust, particularly with the COVID vaccination in these communities, since this will ultimately, in their perspective, be needed to control the epidemic? So generally about mistrust within communities of color and how we can start to repair some of that harm, but in particular with the COVID vaccination.
It's, the trust issue is a very complex and difficult one. We all know about the problematic issues of, well, first of all, I would say that when you look at a population that has not enjoyed meaningful participation in healthcare, the likelihood that they would experience the greatest trust in healthcare is a given, right? And I think part of that issue is, you think about it this way, for most of white America, they don't have to have a good understanding of healthcare. They don't even have to have a great understanding of even how to navigate around healthcare, because the principles of how healthcare functions works in their interest. For African Americans who have not been participants in healthcare, because of the issues that we talked about, under the surface. And then you add the things like, the Tuskegee experiments and those old traditional things. I mean, even though we are far away from this, and this does not occur anymore, and there are great protections, and there are great things that exist. I mean, I myself do, phase 3 trials, and as a PI, so I know what are the safety pieces that are in place for patients or for people of color or otherwise. But it's a generational issue of saying, how do we really get there? The other point about it is that if you take the conversation that's occurring now around vaccination, vulnerable populations are not just vulnerable to the impact of this disease, they're also vulnerable, to conspiracies, and they are vulnerable to the conversations that are really occurring. So I think it's going to be really, really important for us to really utilize pivotal community members, of influence as being modeling out. It's kind of interesting. I think last night I was hearing on the news that, the 3 of the past presidents were going to have the vaccination done openly, to really emphasize, that they are willing to do this. And hopefully that, kind of using this as a bully pulpit to influence others. I think, in our communities, I think structurally that's what we may have to do, is to really identify, whether it's ministers and, bishops and priests and, individuals, that has a connection to community, radio hosts, folks who, I mean, to a large degree, I would search out for rappers and hip hop artists and folks that, there is a cultural connection to. Sometimes, we have to go across the line and meet, even members on the other side, gang members. It doesn't really matter. Really, it's really, emphasizing, how can we, do the hard work of this change that needs to occur with trust. It's not an easy one, and it's not going to be one that's going to happen right away, but it will take action, and it will take sustainable, action to really make that happen. It's a generational effect that I think we are looking at. And the more you get African Americans participating in a meaningful way in healthcare, the more you have more members of African Americans who are members of the workforce in healthcare and so forth. I think you're going to see that lift, that kind of a snowball effect of influences, in the issue of trust.
Great. Thank you, Dr. Nedd. Dr. Orellana, I see you nodding your head there. Is there anything you'd like to add?
Absolutely. I think Dr. Nedd hit a lot of the excellent points. I think, from the state of Michigan and what the public health infrastructure is trying to do, I think the first step is really to listen to groups that are marginalized. And we've certainly been doing that with the Racial Disparities Task Force. We have members from the community. We have group members who are leaders, who are influencers within their neighborhoods. So really, we want to continue to engage key stakeholders, as Dr. Nedd said, and really to kind of look across the spectrum in terms of whether it's religious leaders, whether it is prominent people in the neighborhood, whether it's social media influencers, and then to really make the vaccine and care available in areas that serve the minority communities. So when we're thinking of, we establish those testing sites and we're starting to discuss, is that perhaps an area where we can also offer the vaccine? We've already identified that we are reaching specific populations at a greater proportion than we would at traditional healthcare locations. But next is really to remove the barriers, to make sure there aren't barriers of cost, location, transportation, and then, if we're dealing with the 2-dose vaccine, to make sure that they can come back and get the second dose without any concerns. And then finally, I know that our communications team is working on a campaign that continues to build and to strengthen the trust. Unfortunately, we're kind of at the point, I give the analogy of kind of This is a final test or a midterm test, and we've had all semester to study for it, in the past decade or so. And unfortunately, we've kind of squandered that time, and that's not to diminish the work that's been done, but more importantly to say, okay, instead of stressing about what's in the past, what can we do here going forward, and really to kind of have that unified approach. And that's really what we're trying to do at the state level.
Great, thank you. And I'm looking at time, so this will be the last question I'll ask it of everyone. So we've talked today about really big systemic challenges, and so specifically thinking about racial disparities and equity, what's one thing a person or family of color can do to help improve health disparities? And the second part, what's one thing people who have advantaged identities, our white colleagues or community members, can do to support health equity? Dr. Pelkey, would you mind starting as I put you on the spot?
Sure. Yeah, that's a great question. That's a hard one. So I think one thing that has happened since this pandemic has occurred and other racial events that have occurred, such as the murder of George Floyd, it's brought, like I had mentioned before, a new light to this issue of institutional racism. And I think it's important to have conversations. So maybe it's the same answer for both the person of color and the person who's white, that let's get together and let's talk and let's develop a relationship and begin to understand one another. Having those conversations can be difficult and uncomfortable and emotional. But I think that we need to really begin to understand and to be able to talk with each other and be open to those conversations.
Thank you. Dr. Nedd?
Yeah, I mean, thank you for the question. I'm trying to think of, there's so many things that comes to my mind, as what are the things that we can do. I sharing some of that value that Dr. Pelkey talked about, which is, conversation. To a large degree, having lived as an African American, both walking in the steps of as an individual, because nobody knows what I do when I walk the street, but as a professional, in healthcare, I try to focus on what I believe are the aligning issues that can really bring change. And to me, one of the aligning issues, and I'll go back to it because I think that's the last time I'll speak. I really believe that a model, a value-based principle model that adopts the issue of disparity as a separate quality initiative. It means that, Dr. Orellana is going to be able to now not look back at data to respond or react to what he observes is occurring in the African-American population with COVID. If we are rewarding people for capturing data, then we can be analyzing data to really predict, the circumstances that arise. If there is a flood, or if there is a bad winter, if there is a whatever, we would be able to better, predict and, where these things that would or can be happening, so that we can do the interventions before. And I know it doesn't answer everything, but I think it's a starting place. I want to make it attractive for a provider to want to see people of color in their practice. I want to make it attractive for a hospital to say, I want to see these patients. I wanted to make sure that, a health plan can do the same. I want to make sure that an employer understands, the value of having more people of color in my organizations means that I can address the issue of cost, which is my biggest burden as an employer. those are the kinds of stuff that I think that if we can do, it's a simple ask, but it's an ask that for anybody here who is a business person, who owns a business, or anybody here at Blue Cross Blue Shield is a sponsor of this, anybody from Priority Health, anybody from any of the systems here, if we really want to change this issue of healthcare disparities, we have to put our money where our mouth is. So that's the one thing that I would encourage, and hopefully it can stimulate, real valuable discussions. I see it throughout my career. I still see it, and I believe there's an opportunity here. And as I said, it's not just a moral opportunity. I really believe it's a business opportunity.
Thank you. Dr. Orellana?
Yes. So I think the one thing that our leaders here in Michigan have done and throughout the country, in some areas at least, is to recognize that this is a problem. We've established that racism is a public health threat. And I think that's really the first step towards addressing this. And as Dr. Pelkey mentioned, that will hopefully bring different members to the table to discuss this out. And Dr. Nedd, mentioned, a few of the other upstream factors that, contribute to the issue. The next, I think, is really to acknowledge that this won't be an overnight fix. This is going to be a long, sustained change, and it's not going to be easy. And I think this is an excellent time for leaders as well as folks in the community to express empathy towards one another, that we are going to have some difficulties, but ultimately the outcome will be better for everyone. It's not going to be seen as a cost or a disadvantage to any particular group. But when we have these existing structural racism in place, that really disadvantages society as a whole. So really, the outcome of addressing racism and systems of bias and tearing those down will ultimately make our healthcare and our nation stronger.
Thank you. So dialogue and discussion matter. All three of you said that, and speaking about racial disparities and racism matter. So I'm glad we could model that today. I want to thank you, Dr. Orellana, Dr. Nedd, Dr. Pelkey, for your insights and really for the work that you do. And to everyone who joined us today, a few notes. Our next event is our annual West Michigan Healthcare Economic Forecast, and will take place on January 8th of 2021 from 8 a.m. to 9:45 a.m. Our next Health Forum event will take place on February 5th, 2021 at 8 a.m. and will be on the topic of COVID-19 and protecting our elderly. Both events will be offered virtually, so please watch your email for further registration details. Thank you to everyone who joined us. I'm sorry we could not get to all of your questions, but we hope you have a safe and a wonderful weekend, and please stay safe and keep each other safe. Thanks again for joining us.